Hi, everybody. Welcome to the CREST webinar. Whether you're watching it live on June 26th or you're watching the recording on the YouTube, welcome to the CREST webinar session on prostate MRI. So no financial disclosures. And the objectives of this webinar are to provide a case-based review of the PI-RADS 2.1 and also illustrate the spectrum of anatomic, benign, and malignant pathologies that can mimic prostate cancer. And as most of you know, prostate cancer is the second leading cause of cancer death in men, and the incidence is expected to double by 2030 due to the aging global population. And multi-parametric prostate MRI has been a hot topic during the last decade or half a decade. And the initial morphologic imaging was used solely for the locolesional staging, but subsequent improvements in functional imaging like diffusion weighted imaging has improved its detection capability. And now it's widely accepted by the urology community, and there is significantly increasing volumes all across the world. And the PI-RADS, we have seen PI-RADS version 1, 2, and 2.1, and maybe 3 might be in the coming up down the line. But essentially the PI-RADS risk assessment categories are a 5-point scale, where 1 and 2 are very low and low probability of a clinically significant cancer, whereas 4 and 5 have a probability of high or very high clinically significant cancer. 3 would be the intermediate risk or intermediate probability. And clinically significant cancer is something that we need to know is defined on pathology or histology as a Gleason score of 7 or more, and or volume of 0.5 cc or extraprostatic extension. So this is what we're trying to find. So the objectives of the PI-RADS essentially is to improve the detection of the clinically significant prostate cancer, which is critical in reducing the mortality. But at the same time, we want to decrease the detection of benign diseases or clinically insignificant cancers, so that these patients don't undergo unnecessary biopsies or unnecessary treatment that may potentially cause unnecessary morbidity in these patients. So these are the two essentially the main objectives of the PI-RADS, and there have been seminal papers that validated these objectives. And to understand the grade grouping in relation to the Gleason score that you might have heard in the past. Its grade grouping is much simpler nomenclature, where you have a 5-point scale from 1 to 5, and 1 corresponds to previous Gleason score of 3 plus 3, 6, whereas 2 corresponds to Gleason 3 plus 4, 7. And grade group 3 corresponds to Gleason score of 4 plus 3, 7. And grade group 4 corresponds to 4 plus 4 or 3 plus 5 or 5 plus 3, whereas grade group 5 corresponds to 4 plus 5 or 5 plus 4 or 5 plus 5. It's a much simpler grading system, and so it's much easier. It makes the patients much easier to understand this. And also it's important to essentially understand the NCC and risk categories, where we have a very low risk tumor, favorable intermediate risk tumor, unfavorable or intermediate risk tumor, and high-risk tumor, very high-risk tumor. And so this is essentially what we're trying to detect on MRI, the clinically significant prostate cancer, which may be the favorable intermediate risk cancer or unfavorable intermediate risk cancer, high-risk tumor or very high-risk tumor, which has treatment implications. And one of the things when interpreting prostate MRIs is the diffusion weighted imaging is a very critical sequence. It's important to understand that you need to have either a calculated or acquired high B-value DWIM sequence. And as we see here on this paper, there is improved sensitivity of detection when the B-value is between 1500 to 2500. As we can see here, there is a better tumor to background conspicuity. It increases as we go up to 2500, but beyond that, because of the loss of signal, there is no signal here, and here, because of the background signal with lower B values, there is tumor to background conspicuity is much less. This is very important, and getting an optimal B value or looking at the images, windowing it appropriately is kind of an art as well. And as we get into the first case where we see a homogeneously T2 hypointensity abnormality in the entire peripheral zone of the prostate, which is almost involving the entire peripheral zone on the right side. And as you see here, it's homogeneously high pointance on T2 with marked restricted diffusion extending to the left side of the prostate, almost to the medial aspect. And there is, as you see here, there's dark on the ADC, consistent with marked restricted diffusion. And there is early arterial enhancement as well corresponding to this, all of this. So it is consistent with pretty much a PI-RADS 5 tumor. And as we see here, as we talk about the PI-RADS categorization of the PI-RADS peripheral zone lesions, diffusion weighted imaging is the king, where you see that if the abnormality is marked showing a category of 4 or 5 with marked restricted diffusion, then the final category would also be 4 or 5. The only time it gets bumped up is when the PI-RADS diffusion weighted category score of 3. When the DC is positive, that's the only time it gets bumped up. So it's important to have a very good quality diffusion weighted imaging, especially for the peripheral zone tumors. And the same patient also has this contiguous extension of this high pointance tumor into the seminal vesicles, especially on the right side. And we can see that on the functional sequences of the diffusion weighted imaging and the dynamic contrast enhanced imaging, we see that there is a diffusion restriction and enhancement as well. So this is a T3B tumor with seminal vesicle invasion. And this is something we should be able to identify on MRI. And this is a patient with case number 2, with patient number 2 with bilateral hip prosthesis. And that's one of the things, these patients are older males there is a good chance that some of these patients could have hip prosthesis. So it's important to understand how we can get a good quality images in these patients. And so here we can see that this is the high resolution T2 weighted imaging obtained here. And there is susceptibility artifact, but the susceptibility artifact from the hip prosthesis is much more accentuated, especially on DWI imaging rather than on the T2 weighted imaging. You essentially try to keep the phase direction A to P in this scenario as well to direct the artifact in this direction. And here we can see that there is a focal T2 high pointance lesion. And there is also a breach of this high pointance capsule with extension of the tumor outside the prostate and possibly involving the neurovascular bundle there. And we can see the same thing over here on the coronal image. It's extending close to the levator muscle here, but you can see that there is a fat plane there and it is separate from it. And on the functional imaging, the diffusion weighted imaging, as we can see that there is a bright signal here, dark signal here, consistent with marked restricted diffusion, and there is also early arterial enhancement. So this is a PI-RADS category 5 lesion, and with the T3A staging. And it's extracapsular extension on MRI. It has always been a contentious issue. And recently, the NIH group has come up with an MRI-derived extraprostatic extension grading system. And so as we see here, the grade 1 corresponds to either a broad capsular contact of more than 1.5 centimeter or a capsular bulge or irregularity. With these, the pathologic extraprostatic extension risk is 24%. But if you combine both, then it's a grade 2 and the pathologic extraprostatic extension risk goes up to 38%. Whereas when there is an extraprostatic extension that with frank breach of the capsule, just like in our case, or there is an invasion of the adjacent structures, then the pathologic extraprostatic extension, the risk goes up to 66%. Something to keep in mind when we are reading these prostate MRIs. And what are the strategies to overcome the geometric distortion? So you can the diffusion weighted imaging is the one sequence that's heavily affected by the hip processes. And so you can either minimize the susceptibility artifact by scanning at 1.5 T or doing the DWI with radial case-based acquisition and no fat suppression, or use a reduced field of view DWI, just like as we did, where you can do a selective excitation of that smaller field of view, avoiding the processes, metal. And also you want to do shimming and increase the receiver bandwidth. And you can displace a susceptibility artifact instead of going, instead of keeping the phase direction right to left, you can swap the phase direction A to P. As we go back to this image, we can see that this is the phase is A to P in this setting. This is a reduced field of view DWI. And we can see that the artifact from the hip processes is pretty much in this direction. And this is a selective excitation going on in this particular field of view. And there is hardly any distortion of the prostate in this particular patient. And you can see some artifact here as well from the hip processes. And case number 3, and another patient with prostate MRI, and here we can see that there is a nodule in the peripheral zone posteriorly, and we can see that there is a hypointense rim around it and small cystic focus. And this is, if it is located anywhere else in the transition zone, you would have easily thought that this is a transition zone nodule. As we look at the diffusion weighted imaging, we see that there is no restricted diffusion here. It is showing some shine through on the ADC map, and there is no enhancement. And so this is an ectopic transition zone nodule in the peripheral zone. And this is another case with similar diagnosis where you can see that there is a hypointense lesion in the peripheral zone. But if you go one slice up, you can see that this is contiguous with the transition zone here, and it has a hypointense rim around it. So it's an extruded contiguous BPH nodule. And so extruded BPH nodules are ectopic BPH nodules can create, can be confounding for prostate cancer on both T2 and DWI imaging. And sometimes they may end up getting biopsies. But if you do identify T2 hypointense rim, then if you're pretty confident, you can certainly raise that question and categorize it as a PI-RADS 2 in respect to the diffusion restriction. And sometimes if it's a extruded one, contiguous lysis would be helpful. But having said that, take a look at this case. This is a biopsy naive patient, and we have a prostate MRI, and there is a focal lesion and there is some hypointense rim, but it's not continuous like the other patient, and the shape of this lesion itself is not round. There is some irregularity to it, and it seems to be extending outside the prostate as well. And the diffusion weighted imaging, there is a marked restricted. This is the B100, and this is the B2000. There's a marked restricted diffusion, and it's dark on the ADC. Enhancement, that there is some peripheral enhancement, but centrally there is not much of an enhancement, which is a little bit atypical in this patient. So this is a right peripheral zone lesion with PI-RADS 5 category, and based on the bulge appearance. And so it's turned out to be Gleason 4+3 with Gleason 4 pattern of 70%. So it's important that we recognize that sometimes you can have a T2 hypointense rim around the tumors from tumor-associated inflammation. So when it is not typical, it's okay to call it at least a PI-RADS 3 lesion so that you can get a biopsy done in those patients. There's another patient with prostate MRI, and here we can see that there is this huge mass in the transition zone, which is heterogeneous and moderately hyperintense. And there is interruption of the anterior fibromuscular stroma as well over there, and it's showing marked restricted diffusion. And so this is demonstrating invasive behavior, and this is consistent with the PI-RADS 5 tumor in the transition zone, and especially when there is a bulge anteriorly and there is discontinuity of the anterior fibromuscular stroma, anterior extracapsular extension may also be considered, and provided the urologist is provided this information so that they know this when they're going for surgery in these patients. And so for transition zone, T2 is the driver, T2 is the king. And here we can see that the homogeneous T2 hypointensity is what we look for, and ill-defined margins, also so-called erased charcoal sign, lack of capsule. As you see here, we have a T2 hypointense capsule around the transition zone nodule here, which is all these bright areas are glandular elements, and all these darker areas, like over here, those are all stromal elements. So there is a hypointense rim around this nodule. And lenticular shape is another feature that would be associated with the transition zone prostate cancer. And extension across the midline is another feature that's associated, and because they're larger in diagnosis. And invasion or bulge of the anterior fibromuscular stroma is something we look for, and size more than 1.5 centimeters also. So every patient doesn't need to have all these features. The more the features, the more the confidence level to identify the diagnostic prostate cancer in the transition zone. And as you see here, the dominant sequence for the transition zone is T2 weighted imaging, and here whatever the T2 weighted imaging says, that's what it's going to be, T4 or 5. And so the recent PI-RADS 2.1 came up with a new description of things, which is encapsulated or unencapsulated or partially encapsulated nodules. So this is an encapsulated nodule would be a T2 score of 1, and unencapsulated nodule would be a T2 score of 2, and partially encapsulated nodule would be a T2 score of 2. But at this time, the diffusion imaging plays some role in upgrading these things. So as long as there is no diffusion restriction or minimal restricted diffusion, they remain 2. Whereas the only situation where these nodules are bumped up is when there is a marked restricted diffusion. That's when they can be bumped up at the most to a PI-RADS category 3. And as we see here, this is a patient with elevated PSA levels and multiple negative biopsies. And here we can see that there is an unencapsulated nodule in the transition zone, and there is a marked corresponding restricted diffusion. And, and here we can see that based on this, this is the path that the patient went through: unencapsulated nodule, and there is a marked restricted diffusion went up to PI-RADS 3. So similar abnormality, very identical looking, but definitely a different patient. And here we can see that this is an encapsulated nodule, no restricted diffusion. And so this patient remains at a PI-RADS category 2. And this is another patient with a partial encapsulation. We see a high point dense rim here, and we don't see a high point dense rim in different areas, and there is a marked restricted diffusion. And so this is a partially encapsulated nodule with a PI-RADS score of 3, and the pathology turned out to be a stromal nodule. And so it's there is a confounding factor here. So the diffusion weighted imaging and the T2 weighted imaging, there is a confounding, there is an overlap of features between stroma as well as transition zone prostate cancer. And when the T2 and the ADC are combined, or the diffusion and interpretations are combined, then there is improved sensitivity. But nevertheless, it's something to keep in mind. And there's another patient with a big mass in the anterior transition zone in the midline involving the anterior fibromuscular stroma with causing a bulge. And here we can see that there's a marked restricted diffusion, bright on DWI, dark on ADC, and enhancement. And here, this is a patient with anterior fibromuscular stroma with that is a transition zone tumor, but involving the anterior fibromuscular stroma, and it's a PI-RADS 5 category lesion. So anterior fibromuscular stroma can be thin or can be thick like this, and so it's low signal intensity on T2 weighted imaging, and on DWI, it is not going to show any restricted diffusion, and there is not going to be any enhancement because aglandular. This is aglandular. But on ADC, it may look dark, but it is just the T2 blackout phenomena, because just like I imagine any fibroid or a fibrous tissue would be dark on ADC as well. So similar thing here. Now you need to look at the diffusion weighted imaging. So when you see a lesion involving the transition zone, involving anterior fibromuscular, you apply depending upon where the tumor is originating. Almost 20% of the tumors from peripheral zone and transition zone extend and does involve the anterior fibromuscular stroma. And so it's aglandular. No cancers originate in the anterior fibromuscular stroma itself. It can be centrally thick like this or eccentrically thick like this. And there's another patient where you see a crescentic abnormality in the right anterior transition zone, and showing marked restricted diffusion. And this is a right anterior transition zone lenticular nodule. So you should be able to identify these nodules when they're small or not when they're huge and big. And it's also important to see that this is the corresponding the tumor that we saw, whereas this is the anterior fibromuscular stroma that's thickened. And here we can see that there is no abnormality on the diffusion weighted imaging or no enhancement. And so this is one of the ways to distinguish between the two when you have similar appearances. And this is another patient with a prostate MRI, where you can see that there is some high point and signal here, and there is also restricted diffusion, and there is no enhancement corresponding to this. And on the coronal imaging, this corresponds to the expected location of the central zone that wraps around the ejaculatory ducts and goes down the posterior peripheral zone in the midline, at least to the level of the vermentana. And so that's the key factor. And the central zone also goes around like a dog ear kind of an appearance anteriorly as well. And so it's a PI-RADS 1 lesion. It's not a lesion, but it's a normal anatomy to be distinguished that can potentially mimic prostate cancer. And it's generally symmetric, and it may be showing restricted diffusion. and but it's typically negative as well. And so as we go higher up at the base, one of the things when we talk about central zone, we talk about symmetry and asymmetry. And here we can see that there is a central zone that looks asymmetrically prominent on this side, and there is some restricted diffusion, and there is not much of an enhancement, very minimal enhancement here. So it's important not to overcall, because depending upon how the slice is oriented and if the patient has some atrophy of the prostate on this side, depending on that, there may be some difference in the orientation of the slice here, or there may be slight asymmetry itself. And so the goal is not to overcall the central zone as a potential tumor, but recognize that there is a huge obvious asymmetry, something you want to look for, but at the same time, we don't want to overcall these things. So something to build an experience as we see more and more of these cases. So another patient with, as we see an abnormality here in the posterior prostate here, and as we see on the coronal image, we can see that it's nicely localized to the central zone nodule. And there's a T2 hypointense nodule in the central zone. And on the ADC, it is dark. And on the diffusion, this is a B0, B1500. You can see that there is a marked restricted diffusion and there is an early enhancement. And it's important to recognize this. And this is a central zone prostate cancer. They're rare. And because we don't have any capsule at that level, so it's when they start growing, they're directly causing extraprostatic extensions and melovesical invasion. So then asymmetry is the key, and marked abnormalities on functional sequences like DWR enhancement is the key as well. And another patient with posterior midline abnormality, and we see some diffusion restriction, marked restricted diffusion on the DWR and the ADC. And there's early enhancement as well. So is it just simply central zone, or is it really abnormal? But as we look at the sagittal images, we can see that it is not, it's much, much inferior. It's inferior to the level of the verumentanum. This is the prostate here, and this is the posterior peripheral zone, and this is the bladder here, and this is the verumentanum level here. And so it's much, much inferiorly extending. So this is a posterior midline prostate cancer. And so the key is to identify the location, and so that we don't want to undercall these things, but knowing the location helps. And another patient with abnormality in the posterior prostate at the level of the base here. And so as we see here, more pay close attention here, not all of it is abnormal here. Part of it corresponds to the central zone, and there is a part of that nodule here that corresponds to this, and it's separate from the central zone. It's just sitting next to that. And here we can see that this is posteriorly over here in the peripheral zone at the base. And on the functional sequences here, you see that the central zone shows some mild restricted diffusion, but the tumor itself, the lesion itself in the peripheral zone at the base, it's showing marked restricted diffusion, and bright on DWI, dark on ADC, and enhancing as well. And so this corresponds to a right peripheral zone lesion at the base, so it should not be mistaken for asymmetric central zone, or should not be mistaken for all of this to be tumor. You need to identify the exact location, as well as so that the biopsy can be targeted to that lesion, and we don't want to undercall these things as well. And so this is another patient with prostate MRI. And here we can see that this is the prostate over here, and we can see that there is some asymmetric hypointensity over here. And on the diffusion weighted imaging, there's a crescentic or lenticular restricted diffusion at the interface of the transition zone in the prostate. And so is it just a thickened surgical capsule over there, or is it really abnormal? So that's something to keep in mind. As we see here, this is a thickened surgical capsule in this patient, but on the functional sequences, there is no diffusion restriction, and there is minimal enhancement, but there is no restricted diffusion. But this is clearly abnormal, and so something that can confound. And so using diffusion weighted imaging, you should be able to distinguish thickened surgical capsule from a crescentic tumor along the surgical capsule. So don't rely on ADC map, because you can have this T2 blackout phenomena. And so you can use either transition zone or PI-RADS the peripheral zone categorization, depending upon where it is localized predominantly. And another patient with prostate MRI, and here we can see that there's immediately the eye catches this area of restricted diffusion. And so here you can see that that's in the transition zone, and I would say that there's nothing on the T2 weighted imaging, so I would ignore that. And here, this is as we look at this, and there is it's dark on the EDC map as well. But as we look at all the images here, this is confined, this is localized outside the prostate here. And this is actually localized to one of the periprostatic veins here. And here you can see that the periprostatic vein that we see here is not filled here. And so that's on the delayed post-contrast imaging. So that is a thrombosis of the periprostatic vein that's mimicking an actual peripheral zone lesion. But looking at it on with similar slice thickness series and so looking all of the sequences at the same time, that would help localize it. Once localized, it will be easy to distinguish. And so generally they have a linear tubular configuration, and the anatomic localization should help. And another confounding mimics would be these inflammation and infections like these prostatitis, and we'll see. And here, this is a patient with the diffuse hypointensity of the peripheral zone bilaterally, and with mild restricted diffusion and mild enhancement. And so this is a typical diffuse prostatitis in bilaterally in peripheral zone. And so it can either mimic prostate cancer, or it can affect your sensitivity to detect prostate cancer within the prostatitis. As we see here, this is only mild restricted diffusion, so this is a diffuse form of prostatitis. And this is a focal atrophy, where there is an atrophy of the peripheral zone on this side, but there is no restricted diffusion or anything. So it's not a focal lesion, but atrophy itself. And here we have a wedge-shaped hypointensity with capsular retraction, and there was no restricted diffusion. This is another scarring from the prostatitis itself. And this is a patient who got an MRI, and you can see that 1 year ago, and we can see that there is a heterogeneity in the parenchyma in the prostate, and there is ill-defined signal here on the diffusion-weighted imaging. And also the ADC, there are some ill-defined hypointensities. It looks like a prostatitis, and but the patient comes back after a year, where the peripheral zone at the base has cleared up, and there is much cleaner looking. And now we can see that there are some 2 foci of diffusion restriction. Now, if you go back and look, we do have the same things here, but it is just that the prostatitis around that area kind of created a confounding visual confounding factor there, where it made it difficult to pick that visually. So something to keep in mind. So having said that, chronic prostatitis or the peripheral zone is a major confounding factor, and so you need to look for lesions within it. And so there is an overlap of the ADC of the prostatitis and the prostate cancer. So if the patient, if you find an abnormality within an area of prostatitis, you go for the biopsy, depending upon how much high restricted diffusion is there. And also if the patient is at high risk for prostate cancer, and you might still want to consider biopsy in those settings where you have prostatitis and the patient is at clinically high risk for prostate cancer, you might still want to consider biopsies in that setting. And this is another patient with what looks like a prostatitis on the T2-weighted imaging, but on the high B value imaging, there is a marked restricted diffusion within, not all of that, but within that area. And the biopsy turned out to be Gleason 7 prostate cancer. And so approximately 20% of cancer suspicious regions occur within this dirty peripheral zone, and they do decrease the detection rate and may create poor interreader agreement as well. And so why do we have restricted diffusion with chronic prostatitis? Because of the inflammatory infiltrate. And we talked about the imaging patterns. And so typically these are PI-RADS 3s and 4s mimics, whereas granulomatous prostatitis would be a PI-RADS 5 mimic. And late gadolinium enhancement can predict fibrosis and chronic prostatitis. So something to think. But as we see in this case, this is a paper which talked about the late gadolinium enhancement. This is a wedge-shaped abnormality in the peripheral zone of the prostate, and there is an early enhancement, and there is also much more delayed late gadolinium enhancement. It's easy to imagine that fibrosis would be seen with prostatitis. So this would be helpful, but it's also important to note that 30% of the prostate cancers can also have late gadolinium enhancement due to the presence of stroma. So this is still not a sound strategy to rely on the late gadolinium enhancement for prostatitis, not yet. And this is another patient with prostate MRI, and here we can see that there is an ill-defined linear high point intensity in the peripheral zone of the prostate on the left side. And as we see here, there is corresponding subcapsular restricted diffusion. As we see here is a skinny area, and here on the side, you can see that this is a skinny abnormality here, and there is an enhancement peripherally there. And this is a coronal reformat, which shows the subcapsular location as well. And so this is a subcapsular skinny or thin peripheral zone prostate cancer that can potentially mimic prostatitis. And it's important not to miss that. And here, as you see here, this is a subcapsular hypointensity here. But however, there is no corresponding restricted diffusion in this patient. So this is a capsular scarring in this patient. There is no enhancement, no restricted diffusion. So subcapsular skinny lesions can be easily be mistaken for prostatitis. And because they're subcapsular, there is an increased risk of extracapsular extension. Because they're thin, they may be undersampled on the truss of guided prostate biopsies. And it's important to look at the images very carefully, because periprostatic vessels can easily, we may think that, oh, this is something a periprostatic vessel and not necessarily prostate cancer. So it's important to be diligent about looking each part of the prostate here, especially around the capsule. And this is a patient with history of bladder cancer, intravesical BCG obtained outside the country in Saudi Arabia, and now comes here with the MRI of the prostate here. And so here we can see that on the T2 weighted imaging, we have a necrotic appearing mass in the whole of the prostate, mostly on the right side, extending to the left. And there is a lot of cystic areas. On the diffusion weighted imaging, there is a marked restricted diffusion. And on the post-contrast imaging, there is an early peripheral enhancement, and there is a delayed enhancement as well. So the appearance is pretty much consistent with the prostatic abscess. And this is something that can be seen with the granular prostatitis. And another manifestation of similar granular prostatitis in another patient with bladder cancer intravesical BCG is where you can see that there is a marked T2 hypointense lesions in the peripheral zone bilaterally, as we see here. And you can see that there is a moderate restricted diffusion corresponding to these foci, but not necessarily any enhancement corresponding to these foci. So these are PI-RADS 4 lesions in the peripheral zone as part of the granular prostatitis. So you can have this kind of manifestation as well. So you can have a non-necrotic pattern, or you can have a necrotic pattern with an abscess. And generally they mimic PI-RADS 5 categories. And another form of granular prostatitis is malakoplakia, where it's a rare where it is a rare granulomatous condition from a recurrent infection. And it's not something you can, it's diagnosed simply on imaging. It's something you need to biopsy to make the diagnosis. And post-biopsy hemorrhage is another confounding factor. And so as we see here, T1 signal intensity is the key to identify the post-biopsy hemorrhage in the prostate. And as we see here, this is a patient who underwent MRI after getting a biopsy. And so here we can see that there is an homogeneous, some hypointensity almost all through the peripheral zone bilaterally, but there is hardly any peripheral zone that's spared from the hemorrhage, as we see on the next image here. There is this area of restricted diffusion that we see here in the right left lateral peripheral zone, marked restricted diffusion. There's a somewhat ill-defined hypointensity corresponding to that. And we look at the post-contrast imaging. This is a pre-contrast, and this is the early phase, and this is the subtraction image here. And the pre-contrast imaging, you can see that the whole of the peripheral zone on the right is filled with the hemorrhage, whereas the area that was showing restricted diffusion, you do not have the hemorrhage in there. And there is an enhancement here, but you also have hyperintensity here. So that's why it's important to look at the subtraction images. And here we can clearly see that this lesion that's showing restricted diffusion is enhancing early. And so this is a PI-RADS 4 lesion with grade group 2 prostate cancer. And so something to think about is the hemorrhage exclusion sign. When seen, it's useful. So it has a high positive predictive value, but it's not necessarily seen every single time when there's a hemorrhage. So you can't rely on that to rule out a prostate cancer. So if you see it, it's well and good. But if you don't see it, it doesn't mean there's a prostate cancer. And so it's important to recognize that the rest of the prostate, so you can't rely on just the subtraction images. Here you can see that this is the transition zone prostate cancer that's enhancing on the subtraction images, but you can see that the peripheral zone that has hemorrhage is also enhancing on the subtraction images. So the diffusion and subtractions are also not going to be helpful in this setting. And interpretative pitfalls, because one of the things we all know that is the reader experience and expertise does matter a lot, and there is a lot of subjectivity in there. And so there are several errors we make, and that it's important to learn from those errors. Like it can be perceptual errors, it can be cognitive errors, or it can be satisfaction of search errors. And so we need to take each of them as a learning opportunity, review or follow-up imaging, the biopsies, and try to learn from each of these cases. So this is a patient with who was referred for focal therapy. And let me go through these. The question is, would we proceed with the focal therapy in this patient? And as we see here, this patient initially started off as a MRI outside, the trust biopsy outside some 1 year back, and there was few typical cells. Then that prompted an MRI, and where we found this lesion in the where there was a lesion found in the left peripheral zone anterior crus, and that was biopsied and PI-RADS 4, and now referred for prostate MRI for a focal therapy. And now when we reviewed the prostate MRI, and we find that there is another area in the transition zone that shows restricted diffusion, and when we went and rebiopsied it, that transition zone lesion turned out to be Gleason 7, and when the rebiopsy of the peripheral zone lesion turned out to be Gleason 8. So it's important to not have this satisfaction of search, and that may result in incomplete mapping of the tumor itself. And as we see here, this is another patient with T2 weighted imaging. And here we can see that there is this diffusion abnormality here in the anterior apex that was never called on the left side. And here there is a restricted diffusion, there's a bright signal and dark signal here. And as in the sagittal images, you can see that this corresponds to the anterior aspect of the peripheral zone here at the base. And here we can see that that's corresponding abnormality there. And so this corresponded to Gleason 6 tumor in this location. And so this was not originally called, but subsequently picked up during one of the tumor board reviews. So it's important to recognize this, that there are pitfalls, especially at the apex where, and when they're small, there could be volume averaging. And another patient with elevated PSA levels, multiple prior negative trust biopsies, and there is an abnormality here or here. I'm going to show you a cine here, but here I want you to pay attention here. This is the urethral sphincter here. This is a subapical region inferior to the prostate, and here you can see the urethral sphincter that's hypointense, and you can see that there is an interruption here, and this is all the tumor. So this is a subapical extension of the tumor, and there is corresponding marker restricted diffusion and early enhancement. Let me show you the cine here. So pay attention to the arrows here, and you can see the actual location of the tumor and the subapical extension. Something to pay attention to, because this is a patient who underwent MRI after multiple negative biopsies, and apex is one of the difficult areas on trust to identify that. Look over there, that's the tumor there. And here you can see the involvement of the invasion of the urethral sphincter. I'm going to play again one more time, or grab that and see that that's this apex tumor and the peripheral zone extending inferiorly, and there is invasion of the urethral sphincter that's interrupting that hypointense line of that urethral sphincter there. And so if the patient undergoes prostatectomy, there will be positive margins. So that's not going to be an option in this patient. It's important to document that. And this biopsy turned out to be Gleason 9, 5+4. And so another kind of patient where you see a rounded appearance in the urethra, and this can easily be passed off as just a urethra and periurethral transition zone. And here it looks prominent, and on the diffusion weighted imaging, you can see that there is a marked restricted diffusion corresponding to this, and there is an early enhancement as well. So periurethral region is another area that people can easily miss tumors, and is a PI-RADS 4 tumor. And so the apex, base, subcapsular presenting tumors, midline subcapsular crescentic tumor, sparse peripheral zone tumor, central zone tumor, periurethral location of the tumor, occult tumor, and prostatic hyperplasia. So these are some of the locations where tumors can easily be missed. And this is another patient who underwent an MRI with the endorectal coil. And here we can see that this is the T2-weighted imaging, ADC map, and this is dynamic enhancement. And this is a sagittal image over here. And so here, as we see on the sagittal image here, we can clearly see that there is this hypointense mass anteriorly that's pushed and compressed by this peripheral zone. And on the T2-weighted imaging and the dynamic enhancement, we can see that this is the transition zone mass that was essentially because of the compression by the endorectal coil. The typical appearance is not necessarily seen, but it looks more crescentic because it's so much compressed. And clearly the enhancement is clearly outlined. It's separate from the rest of the transition zone enhancement and looks different. And it enhances, it appears like a mass separate from the transition zone. So that was biopsied, and it turned out to be Gleason 3+4 and underwent ablation of this, one of our first ablation patients. And so unfortunately that wasn't picked up, but we were calling whoever was reading this as calling abnormalities in the peripheral zone because there was hyperintensity, but then none of these were diffusion restricting. So it's important to look at everything. And this is another patient with history of rectal cancer. And so 3 centimeter invasive adenocarcinoma of the rectum, and patient underwent transanal excision, and the margins were negative. And we got a rectal MRI for staging purposes. And here we can see that this is the hypointense scar in the wall corresponding to the area of transanal excision. And there is this mesorectal lymph node here that's abnormal. So it's an N-positive staging for the rectal cancer. And but also in these patients, it's important to pay attention to the prostate as well, or pay attention to the rectum in patients with prostate MRI as well. So either way, so you need to look at both. And here we can see that there is a focal hypointensity here, and at the same time there is a corresponding early arterial enhancement corresponding to this. And on the diffusion weighted imaging, there is restricted diffusion on the B1000 and the ADC map over here. And this was biopsied, and this is a PI-RADS 4 lesion, and we did an indoor MR guided biopsy, and we can see that this turned out to be a Gleason 6 tumor. And so when interpreting rectal MRI, important to pay attention to the prostate. When interpreting prostate MRI, pay attention to the rectum, and look at the bladder as well. So you can have cancers in either of these locations, so it's important to pay attention to these things. And when synchronous, the morbidity is generally caused more by rectal cancer rather than a prostate cancer. So it's important to keep that in mind. And it's also important to keep in mind that prostate cancer can be associated with colorectal cancer in patients with Lynch syndrome and men with the germline variants of DNA mismatch repair genes. And this is one of the earlier patients we saw here. And so this was biopsied in the transition zone mass here. It's a PI-RADS category 5, but it's a high-grade pin. And so the question is, what do you do next? And so we look at the fusion biopsy images, and we see that this is the capsule of the margin of the prostate here, and this is the outline from the MRI itself. So there is a mismatch of the MR ultrasound registration, and the tumor is actually located. So this is the needle track, and so the needle actually never went into that. So it's something to keep in mind. So in those patients when PI-RADS 4 suffice, the M biopsies are inconclusive, or they're negative, it's important to pay attention to these fusion images. And if you still think that that's a real abnormality on MRI, you might want to reconsider rebiopsying these patients. And another patient on active surveillance, and so this was a Gleason 6 tumor, grade group 1 tumor in the left peripheral zone, showing restricted diffusion. And the current MRI, obviously there is an increase in size. And there's, if you look at the PI-RADS, there's still PI-RADS 4, but obviously there is an increase in size. That's why there is this precise scoring used for these active surveillance patients. And this could be, this is scored as a 4. And this could be an indication to rebiopsy for potential Gleason upgrading in these patients. As we see here, the score of 1 to 5, and so significant increase in size in this patient, and definitely consider rebiopsying these patients. And I will let you read all these things on the video itself, each of these categories. And one of the last patients that we're going to discuss today, and this is a patient with large mass in the involving all of the prostate here. It's homogeneously hypointense, and there is some central necrosis, and it's showing marked restricted diffusion and marked enhancement as well. And so the diagnosis, it could have been a sarcoma as well, or it could be a stromal tumor of uncertain malignant potential. And it turned out to be a stromal tumor of uncertain malignant potential. It's considered neoplastic since it can recur. And so 16% of them, these can be associated with sarcomas concurrently or subsequently. And so they can, one end of the spectrum, they can mimic, they look solid and can mimic sarcomas, and the other end of the spectrum, they can look cystic and mimic aggressive BPH nodules. And when in question, always go ahead and biopsy these as well. And this is another patient with very large mass in the peripheral, in the right side of the prostate, and it has multiple cystic areas within. And as we go further down on the diffusion weighted imaging, there is hardly any enhancement. This is all shine through from the cystic areas on the V100 and the EDC map. And there is not much of an enhancement either. And there are some ill-defined T1 hyperintense areas within, but there is hardly any enhancement of the cystic areas. So this one could be an aggressive BPH nodule kind of variant of the stump, or could also be a mucinous adenocarcinoma. So mucinous adenocarcinomas, they can be small as well. And when they're small and they're in the peripheral zone, they can be T2 hyperintense, and they look like the rest of the peripheral zone as well. And it's difficult to detect them. And on diffusion weighted imaging, the mucin component not sure restricted diffusion, and the T2 shine through because of the T2 shine through. And they're defined by, some of them, they're defined by presence of more than 25% mucin. They're very rare. And because when we do the biopsies, people look at only the cells. So the diagnosis is not necessarily made at biopsy rather than at the prostatectomy. And they're considered to have a little bit favorable long-term outcomes. But the International Society of Urologic Pathology categorizes these tumors as Gleason 8, which brings them into high-risk category. So that's the end of the presentation. Whirlwind tour of the prostate MRI, and hope you all got something out of this. And so it's important to recognize that high-quality PI-RADS compliant prostate MRI and awareness of the benign mimics and pitfalls is critical to the success of the MR-directed biopsy program. It's whoever is reading these prostate MRIs need to be collaborated with the urologists and provide a high-quality patient care. Thank you so much for the opportunity, and I'm sure some of you might have questions, and I should be available on June 26, 2021 to answer any questions. Thank you so much.